at Harvard and the Brigham and Women's Hospital. He is the president of the Pacific Heart Institute. He's the director of the Heart Failure Center over there, and he is the past president and governor of the California chapter of the American College of Cardiology. So, won't you please welcome Dr. Wright?
Well, thanks very much. Thanks, Mo, again for having me back for a third or fourth time. I can't remember exactly. I've been charged today with talking to you about heart failure, and I just want to point out that heart failure, along with atrial fibrillation, is one of only two cardiac diagnoses that's increasing in frequency. So, those of us who live long enough are destined, as I'll show you, to have a significant likelihood of heart failure, and thus I think it's apropos. And I'm going to talk about kind of in the trenches. I see patients every day, and although we do a lot of clinical research and things, what I'm going to try to focus on is what do you do for somebody who's in your office today with a diagnosis or a suspected diagnosis of heart failure. So this will be practical. I'm not going to talk about putting in biventricular pacers and that kind of thing. This is mainly pharmacologic management. These are my disclosures. I do serve on speaking faculty for many of the pharmaceutical companies that make products, but I can assure you nothing I'm going to say is outside of the guidelines and things. So let's start with a patient. Some of you have seen this case before. I presented this particular individual. Blood pressure is 120s. This is a new consult to me. Heart rate's 140 and atrial fibrillation. I couldn't really see the neck veins. I'm going to spend a lot of time talking about neck veins in a bit. But there was a mitral regurgitation murmur, and there was edema, interestingly, only of the scrotum. No edema of the ankles here. And there was poor R-wave progression, looked like prior anterior MI. Here's the chest x-ray. And I can assure you this was not a pericardial effusion. This was an ejection fraction of 10%. And obviously, looks like that's pretty bad. Well, here's the patient, right? What you didn't hear is that I do the cardiology, or did for 10 years, for the great apes at the LA Zoo. And I don't want to dispel anything about diet, but I'll tell you that the great apes are obligate vegetarians. In fact, they're vegans. All they eat is the most perfect diet, and half of them die of coronary disease, including this one, Toto, who at age 52 was deposed from his throne. You know, the way the apes work is that there's an alpha dominant male, and he had a harem of 5 women, and all these young males are always trying to depose him, and he had just been deposed, and his wives were stolen, and the reason was because he couldn't fight anymore because he had heart failure. Right? So, poor Toto. He lived a few more years before he died of heart failure, actually. I may be one of the few people in the world who's done CPR on a gorilla, because one of my gorillas, while I was doing a transesophageal echo for heart failure, actually went into ventricular fibrillation, so we did CPR on a 400-pound gorilla. So what is heart failure? A few years back, I was a co-author of the U.S. Guidelines on Management of Heart Failure, and the government convened a panel of experts, and as Chris will tell you, when you put a bunch of experts in a room, you can't agree about anything. And it took us 6 months to decide what heart failure is, because heart failure is not a disease. There's no single blood test you can use to define what heart failure is. So it's a syndrome, right? And therefore we had to say, what is the syndrome of heart failure? Well, this is the definition that we kind of agreed upon. This is a variation of Gene Braunwald's definition from many years ago, in which heart failure is a situation in which the heart doesn't do its job, right? And then what's the job of the heart? The job is to pump adequate volume and pressure of blood, right? That's the main function of the heart. But it has to be able to do that without flooding the lungs or the body. So if it can pump adequate amounts of blood at an adequate pressure without flooding the body, then you don't have heart failure, okay? That syndrome of the heart being incapable of doing its job, as I mentioned, is very common. And these are lifetime data from Framingham. This is the original Framingham cohort, followed for 26 years, starting in their 50s. And it turns out that if you don't have heart failure at 50, that's great. If you don't have heart failure at 60, that's great as well. But the longer you live, the greater your likelihood that in the next year you will develop heart failure. And what you see is that at the end of the life of the person, 20% of the individuals had been diagnosed as having heart failure. This was years ago, before we had MRIs and all sorts of things. So this is honestly probably an underestimate. This is a clinical diagnosis of the syndrome of heart failure. So this is really common, and this is as common, for example, as atrial fibrillation. Not as common as atherosclerosis, but of course these things are linked because many people with atherosclerosis will develop heart failure. And as you heard, hypertension is one of the main contributors. And we'll talk, I'm not going to spend a lot of time on the pharmacology of patients who have heart failure syndrome with good ejection fractions, but overwhelmingly those are hypertensive elderly individuals. So that's by far the number one cause globally in the world, followed by myocardial infarction, and then a bunch of other things that lead to cardiac dysfunction. Importantly, the second from the bottom there, toxic agents, chemo is becoming a very important cause because most of the breast cancer drugs, in fact, have off-target effects on the heart. So if you do selective testing with speckle tracking, strain rate imaging, and things that we do, 25% of all the women who get chemotherapy for chemo for breast cancer will have heart failure. Maybe not manifest clinically, but we can detect it actually in the echo lab. So the causes of heart failure can be, I think, sort of physiologically grouped very easily. Okay? The one that most of us think about is this one, which is failure of the pump. The pump is just not strong enough. And that's about half the patients, right? So I run our heart failure program. Of all the people sent to me with heart failure, half of them fall into this category. In the world, the most common cause of pump failure is myocardial infarction. And historically, about 60% of all the people with reduced ejection fraction heart failure, poor pump, have had a prior infarct as the purported cause of their systolic heart failure. The other 40% are everybody else. And I've listed them here as sort of primary heart muscle weakness. The most common of that group is cardiomyopathy. And we used to call it idiopathic dilated cardiomyopathy. Turns out most of these people actually, if you genotype them, have a protein abnormality. It's not a virus. We used to call it viral cardiomyopathy. That turns out to be very rare. The majority of these people actually are just prone to having heart failure because they've inherited a bad protein. There are hundreds of different mutations. There are about 50, 60 common ones that we genotype people for. But I'll tell you that it doesn't matter if you genotype them because as of today, there are very few mutations that would lead me to make any different recommendation than the recommendations we're going to make about how to manage these people. So dilated cardiomyopathy is primarily a genetic disease that's manifest and triggered by things that we don't fully understand. Sometimes it's just time. Sometimes it might be a virus that triggers it. But it is the second most common cause for low ejection fraction heart failure. And then there's impaired filling of the heart. Those are the other 50%. And those are mostly the hypertensives. They're usually older, as I'll show you. They're more commonly women because women live longer and hence they have a greater number of years of exposure. There are many different causes of preserved ejection fraction heart failure. Okay? Hypertension, we mentioned, is the most important globally. But I'd like to point out the last one there, internal constraint or deposition of abnormal substances. So it turns out upon further investigation that 20% of the people that you carry with a diagnosis of so-called diastolic heart failure, somebody with the syndrome of heart failure with an ejection fraction of 60%, for example, 20% of those people have amyloidosis. And that has emerged by far as the most common cause that is potentially treatable. So anybody that gets sent to me with a diagnosis of diastolic heart failure immediately gets checked for amyloidosis. And I would encourage you to do that if you have somebody who has unexplained diastolic heart failure. The most common is transthyretin amyloidosis, and that's totally discoverable now by getting a technetium pyrophosphate myocardial uptake scan. It's 98% specific for the diagnosis. You don't do a biopsy, you don't do any blood tests, you do a single nuclear scan, bingo, you have the diagnosis. That's the most common. The second most common is a variation of multiple myeloma, plasmacytoma, where somebody has an abnormal immunoglobulin. So for those of you who have an interest in that, just send free kappa lambda ratios and you can pick up the rest of those particular people. Now, regardless of whether your ejection fraction is 20 or it's 70 and you have so-called diastolic or HFpEF, the consequences are the same. And most patients don't come in saying, gee, I think my ejection fraction's bad or that I have infiltrative cardiomyopathy. They come in because they have symptoms of congestion, right? So the most common symptom by far is congestion. That could be flooding of the lungs, and anything that causes the left side of the heart to be abnormal floods the lungs. Whether it's a bad valve, whether it's thick heart, whether it's a weak heart, the symptom of that is breathlessness, right? Dyspnea. That's flooding of the lungs. Now, if you have flooding of the lungs in the peripheral tissues, that can be due to left heart disease, but it could also just due to right heart disease, right? So the right heart that pumps blood to the lungs might be struggling and failing. The left heart could be totally normal. And in those people, they don't have flooding of the lungs. Usually the lungs are fine, but they have flooding of the peripheral tissues, right? So right heart failure, cor pulmonale, that kind of thing, which can lead to peripheral edema, perhaps in the absence of any flooding of the lungs. But in either case, the kidneys are instructed, and you could argue they're misinstructed, but they're just listening. They're like the privates in the army. You know, the kidneys are dumb. No, I'm just giving Chris a hard time here. That the kidneys are listening to instructions, and if the heart is struggling, the kidneys will be instructed to hang on to salt and water. And hence the congestive state is really a reflection of the kidneys, not a reflection per se of a direct cardiac abnormality. So here's the definition of systolic heart failure, and it turns out it's far more complicated than we perhaps would think, but the easiest number to remember is just the ejection fraction, and that can be obtained whether it's in the cath lab, in the echo lab most commonly, or in the nuclear lab, or now by CT, by MR, doesn't matter. Normal's above 55, and most people in my clinic who have this diagnosis are below 40. Most of the trials on which the data that I'll base my recommendations in a minute on would define this as less than 40, with a typical person being around 30%. So that's the typical systolic heart failure patient. It's not just squeeze. 100% of these people have diastolic dysfunction as well, because when your heart squeezes, it stores kinetic energy, and that energy is then released during relaxation. And so the heart actually has active suction. It doesn't just propel blood and then sit there flaccidly. It sucks blood from the atrium and the lungs back into the heart for the next beat. And if you don't believe me, just take a heart from an animal, for example, detach it from its blood vessels and it's still beating, put it in a jar and it'll squirt around like a squid or something moving around. And that's because it sucks blood in and ejects it, sucks blood in. And so all the patients with reduced ejection fraction heart failure, part of the problem is they don't have enough suction and they can't fill the ventricle. The ventricle also, your ventricle twists and torques every heartbeat, and then in the relaxation phase it uncoils, and that's part of the suction process. So all those things are abnormal when patients have reduced ejection fraction heart failure. So these are the 50% of people with HFrEF, heart failure with reduced ejection fraction. Those are the ones in which the data are most solid and which will base most of our recommendations. The other half have a heart that looks like this. It's a stiff, thicker heart. This may have an ejection fraction that's totally normal. Could be 60, 70, could be 80 or 90 if somebody has, for example, hypertrophic cardiomyopathy. The problem here is twofold. One is that the heart may not relax appropriately, and hence the pressures to distend the ventricle are higher. Those pressures back up into the atria, causing things like edema and lung flooding. And very importantly in these patients, the stroke volume, the amount of blood pumped by the heart per beat is reduced because the chamber's too small. So you can have a person who has perfectly normal systolic and maybe even perfectly normal diastolic function, but the total amount of blood pumped per beat is inadequate even at a heart rate of 100 or 110 or 120 to meet the needs of the body. And remember, our definition of heart failure included that you didn't pump enough blood. So there are people that actually just have low stroke volumes. And I'll tell you, those are the ones that we as heart failure experts have the hardest time dealing with, because trying to improve stroke volume in a heart like this is exceedingly difficult. This would be like an amyloid patient, for example. Now, if you look in, this is a very common type slide that showed, and it claims that it doesn't matter whether your ejection fraction is 20 or 70. If you have heart failure, this is your mortality in hospital, post-hospital, and 60-day mortality post-hospital, etc. It's the same. Be very careful when you see data like this, because the people in the purple color, those are the people with preserved ejection fraction, are all old people. And guess what? Old people have shorter lives and get admitted to the hospital more. So if you ask the question, what percentage of hospitalized patients with the clinical diagnosis of heart failure have reduced or preserved ejection fraction? Here is preserved ejection fraction heart failure. Somebody comes into the hospital with diagnosis of heart failure and they're 50 years old. That person does not have diastolic heart failure, almost rarely, right? Whereas if you have an 85-year-old, half or more, it's their preserved ejection fraction heart failure. So the reason the preserved ejection fraction patients look bad is because they're old people. You know, that's why. If you look at 60-year-olds, it's better to have preserved ejection fraction, assuming you don't have amyloidosis, than it is reduced ejection fraction heart failure. So just one little caveat there. So first pearl. Heart failure is bad no matter what the cause. That's true. The mortality is clearly higher if you have heart failure than if you don't have heart failure. It doesn't matter whether you have a coronary disease or amyloid or if you have constrictive pericarditis, it makes no difference. But I will tell you that every single patient who presents to our heart failure clinic can be helped. Everybody. With the things we're going to talk about, this is not throw in the towel, send her out behind the barn. This is, you can make people better. And what it is just the art of medicine. It's the judicious use of medications mostly and devices in selected people which will save the day for those people. So how do you make the diagnosis of heart failure? Well, the first thing would be signs. This is what patients would complain of potentially. The cardinal symptom is breathlessness. That could be with activity or it could be at night lying in bed. Peripheral edema, of course, another one of the cardinal complaints that patients complain of. Weight changes, it could be up or down. Mostly we think of up because of congestion, but you can have cardiac cachexia due to heart failure and actually have a declining. That's actually the worst group to be in. If your body is shrinking because of heart failure, you're really in bad straits. And then there's the symptom of bendopnea. This was something that was coined a couple of years ago. You've all had this, patients say, I get so short of breath when I bend over to tie my shoes, and we always just blow it off. And yeah, right, you're fat, whatever. Turns out none of these symptoms, unfortunately, are unique to heart failure, and that's the problem. Somebody could come in and you think they have heart failure, and they don't. They have a pulmonary embolism, or they have chronic obstructive lung disease, or varicose veins, or a bunch of other things. That's why the signs of heart failure, the symptoms of heart failure in and of themselves may not make the diagnosis. You can be suspicious, but they may not make the diagnosis. Now let me just give you evidence that bendopnea is actually one of the most important of those. It's much more specific for heart failure than the other ones that I just mentioned. And this has actually been confirmed by Wright heart caths in people who complained of bendopnea. These people all actually happened to have heart failure. It was in a heart failure clinic that this particular data slide comes from. But what it tells you is that if somebody says that, just think that maybe they need more diuretics, because look at the data here. The right atrial pressure was 11 versus 6 if they complained. These people all had low EFs, right? And their EFs were matched. But if you had bending over caused you to be short of breath, you had a higher right atrial pressure, a higher wedge pressure, a lower cardiac index, and a lower mixed venous oxygen saturation, you were in more heart failure. So that's a symptom to me that would cue in that I need to be more aggressive with medications if somebody tells me that they have shortness of breath bending over. The physical exam still plays a role, and I know there are people in San Diego particularly who say we don't need the stethoscope, all we need is an ultrasound that the intern could put on the person, and no more tests are needed. And that could be the furthest from the truth, let me tell you. So there are things at the bedside that make a difference. And the most important is the first one listed there, jugular venous distension. Okay? There is no disease that causes jugular venous distension other than heart failure, and then a rare person who might have tumors in their chest or something. But if you see the neck veins are elevated, and they truly are elevated, I'm not talking about Schwarzenegger 40 years ago, where his veins were popping out all over his body. I'm talking about somebody who's just in your office. And usually I see this when I'm just talking to the patient. I look over at their neck and I record their neck pressure looking while I'm typing on my computer these days. Of course, listening to the lungs, listening to the heart for S3s, S4s, murmurs. What I've listed here is abdominal jugular reflux, often called hepatojugular reflux, but it's really not the liver that you're compressing, it's the belly, a very important sign. Right? What does that mean? You press on the belly, you transfuse a couple hundred cc's of blood that are in the venous capacitance blood vessels in the belly, and you transfuse those just by pressing on the belly, and it enters the heart. If the heart cannot accommodate that, the neck veins will distend. There is no normal heart that has hepatojugular reflux. So if I see that immediately, I know there's a problem with compliance of the right side of the heart. And of course, edema, useful maybe chronically, less useful right away because you don't know for sure whether it's just venous insufficiency or DVT or hypoalbuminemia or bed rest or a whole bunch of other things that can cause that particular problem. Chronically, RALs are useless for heart failure patients. And I'll tell you, you can come to my clinic and there'll be people with wedge pressures of 40 millimeters of mercury, your lungs sound perfectly clear. Because the longer you have heart failure, the more your lung lymphatics buff up and are able to drain that fluid away. So RALs are useless. You almost never hear them even in the worst decompensated patients in our chronic heart failure clinic. Now, that isn't true for acute heart failure. The first slide I showed you a moment ago was acute heart failure. If I made your heart filling pressures go up to 30 or 40 right now, you'd be bubbling and you couldn't breathe. So acute heart failure is different than chronic heart failure. If somebody has elevated neck veins, this is just what happens over the next 5 years. You just take one data point in a heart failure clinic, somebody has neck vein elevation or not, and follow them over time. If they have neck veins that are elevated, they do dramatically worse over the next 5 years because there are more heart failure. So spend time learning how to look at the neck veins. And I can tell you, I've hired every person at Pacific Heart Institute. I've never had one cardiologist come to me who knew what the heck to do with neck veins, unless they went through a heart failure program. Because most of us just blow it off. We don't look at the neck veins. I was going to show you, I just took literally 9 sequential patients that appeared at my office earlier this week. And I just photographed their neck veins to teach you guys how to do it. Unfortunately, I can't play the videos here. But it's very simple. If somebody is lying on the normal exam table and you can see the neck veins above the head of the clavicle, their neck veins are elevated, right? Because the normal venous pressure should be less than 5 centimeters of water, and that's just at the level of the clavicle. If it's up to the mandible, that's 20 centimeters. So between 5 and 20 is about the highest you'll see. If somebody's sitting in the exam chair or sitting in a chair when I'm evaluating and I can see their neck veins, that's abnormal 100% of the time. You never should see neck veins sitting bolt upright. Because sitting bolt upright, the venous pressure is below the clavicle and it's in the chest, you can't see it. You can use the external jugulars perfectly fine, with the exception of the Schwarzenegger type guys that I was talking about, where neck muscles will impinge on the vein and make them pop up. So if you see veins popped up all over the place, that doesn't mean the central venous pressure is high. It usually means they have a lot of muscle mass. Well, my average patient's 82. Not a lot of them have a lot of muscle mass. And then you learn a lot more, right? You look for big V waves, which come from tricuspid regurgitation. You look for the abdominal jugular reflux by just pressing and making sure they're not holding their breath, because everybody that holds their breath and tenses up their thorax, the neck veins will distend. That's normal. So you want to do it during normal inspiration. There's lots of stuff on the web you can look at, which will teach you how to do this. But at the bedside, this is the single most important finding. And you can see my array of 9 patients in one day, they're all of whom had neck veins. So I want to just say, put in a plug for carefully examining the neck veins. It takes less than a minute. And it's a lot more useful than getting a BNP, for example, in these people. Use that to help guide the therapies that we're going to talk about in a minute. Because if their neck veins are barely demonstrable versus they're up to the mandible, you're going to think differently about, should I double the diuretics? What about the spironolactone? Are they on a good enough dose of a renin-angiotensin modulator, etc.? So just to dispense with the HFpEF people, right? Heart failure, ejection fraction, 60%. Doc, what are you going to do? What's going to make those people better? Well, what therapies are proven? None. None, unfortunately. Now, I'm going to use a little caution here because spironolactone probably is useful in these people, but you may remember there was an international trial done using spironolactone in these people, and unfortunately, a bunch of the patients were enrolled in Russia and Georgia. I don't mean Atlanta, I mean Georgia next to the Ukraine, and those people were enrolled and didn't have heart failure, and guess what? They didn't benefit, And that dragged down the results. But if you look in the United States and Canada and other places, patients with HFpEF do benefit from spironolactone. So it's probably good. You won't find it in the guidelines because the international outcomes trials failed to show benefit because the data were unfortunately besmirched. But the general treatment of heart failure, and the general reducing excess volume that we're going to talk about here, holds for both HFpEF and for HFrEF, reduced ejection fraction. So reducing volume is the single most important initial step you can do to make your patient feel better. That's what patients will be gratified about, right? Oh my gosh, I can breathe and I can put my shoes on again. So how do you reduce the excess volume? Well, usually we use diuretics. The first diuretic came out in the late 1950s that worked. I was talking to Chris earlier. That was a mistake of pharma. They were looking for a new agent that was a sulfa derivative that they were looking for as an antibiotic, and lo and behold, it turned out to be a diuretic, the first thiazide. So they stumbled across that, and now we have many different diuretics that are useful for heart failure patients. Usually in the heart failure world, the thiazides aren't considered potent enough, so normally we use loop, so-called loop diuretics, right? And there are commonly used ones. The most common by far is furosemide. And furosemide has one advantage: it's dirt cheap, as I'll show you in a minute. However, it only lasts 6 hours, and it is not well absorbed, particularly when somebody has decompensated heart failure. So I would caution you that there's a lot of, it's not resistance to the effect of furosemide, it's malabsorption of furosemide. And that's why the drug works so well when you put somebody in the hospital and give it to them intravenously. In the heart failure clinic, we prefer torsemide. And that's because it's better absorbed even in the edematous gut, and hence it's more effective. Often, though, we need to combine it with other diuretics. So you're attacking different points in the kidney to allow the kidney to ignore the instructions that are being given from this heart failure syndrome, and hence produce more normal quantities of urine. So very, very commonly we employ a loop diuretic combined with something else. That could be a potassium-sparing diuretic, most commonly spironolactone, or you could combine it with a thiazide. In the heart failure world, mostly metolazone. Now, just to show you that the diuretics are not all comparable, left to right is the number of milligrams it takes to achieve diuresis. The vertical axis is how much diuresis, or in this case natriuresis, you achieve. And left to right are bumetanide, torsemide, and furosemide, all loop diuretics. So what do you notice? First, bumetanide is the most potent per milligram. That's why you give small doses, like a half a milligram or a milligram, instead of furosemide, which is the weakest, where you're giving 20, 40, 80 or more. But the most effective in terms of getting rid of more salt is torsemide, right? That's the vertical axis there. So that's one of the reasons why we prefer torsemide rather than bumetanide and furosemide. Secondly, just be aware that these drugs are not interchangeable. Okay? It's not just the effects on sodium handling and how many milligrams. There may be differences that are biologic. Now, the reason I included this slide is because there is this, for 20, 30 years now, there's this background in the heart failure world that loop diuretics might harm people over the long haul. And that's because in every study, the people who are on lots of diuretics do more poorly. Now, of course, you could argue that's because they're sicker, that's why they need more diuretics. That absolutely could be true. And very smart people have tried to go through this. But just to point out, this is a particular slide looking at heart fibrosis by heart biopsy. And they actually randomly assigned people to torsemide or furosemide and showed that there was more scarring with furosemide than there was with torsemide. So it's conceivable that some off-target effect of these drugs may actually harm the heart failure syndrome in some way. And the reason I point that out is, using the other drugs we're going to talk about, if you get somebody well enough, it would probably serve them well to back down on, or maybe even back off, loop diuretics. In fact, for people currently in the United States waiting for heart transplants, 20% of them are on no diuretic at all because they're not volume overloaded. So diuretics are terrific for symptom alleviation and congestion alleviation. There may be a downside. If you can get the person off it, that's great. And the way you get them off it is by making the heart better. How do you make the heart better? Well, you can use other drugs that we'll talk about in a second. The last thing to remember is cost. Your hospital will be apoplectic if you want to give IV ethacrynic acid or edecrine, right? One dose costs $2,350. That is preposterous and ludicrous, and nobody should, in my view, get that drug, with rare exception. You can see the rest of the drugs aren't that expensive. Orally, the reason furosemide is liked by the PBMs is because it costs 4 cents a pill. These are the actual procurement costs for our health system that I cajoled pharmacy into giving me. So you can see that hydrochlorothiazide only costs 3 cents. I prefer chlorthalidone, although it's 20 times more expensive. Chris, did you know that? It's 60 cents a pill instead of 3 cents a pill. So just keep that in mind. So how do you improve diuresis? If the person is still volume overloaded, get rid of the middleman, meaning the gut, because that's where these drugs are all absorbed. We do that by giving IV diuretics in the office, right? So I never admit somebody to the hospital for decompensated heart failure, with rare exception. They just come to the office, I squirt an IV furosemide. The next day they come to the office, I squirt an IV furosemide. We send them home with a little IV in. That's all you need to do. You don't need to You going to hospitalize the patient to babysit them while they're getting diuretic therapy? Come on. Or you can switch them to oral torsemide. Works like a charm. So that's why you can get down the hospital readmission rate, which your hospital will love because they don't want to be penalized. And I don't know about here in Reading, but across the United States, 65% of all the hospitals last year were fined for having readmissions that were considered excessive by Medicare. And then, as I mentioned earlier, very commonly, if somebody's on a reasonable dose, and by reasonable I mean they're already on 80 QD or BID of furosemide, or we use high doses of torsemide, right? 20, 50, 100. If they're not diuresing on that, they need a second drug. And the first we would go for is spironolactone. Much like Chris, I'm a big believer in that drug, and I'll show you why in a minute. But the combined loop plus spironolactone really works remarkably well in these people. Now, what about sodium and salt fluid restriction? Notice I put a question mark here. Every guideline, every textbook, and most doctors and nurses will say, well, I'm going to tell Mrs. Jones not to eat as much salt and take less water because if she's volume overloaded, that makes sense. And it does make sense. It's just not right. Okay? There have been 3 randomized trials for salt restriction in heart failure. All 3 showed that salt restriction was harmful. Now, of course, the textbook editors and guideline people weren't very excited about putting that in there, so it doesn't appear. But here, in fact, is this is a very large group of, this particular one is not a randomized trial, but there are 3 randomized trials. This was a big observational study where they tried to propensity match and do everything they can do. In red is individuals who are salt restricted, in blue, not salt restricted. The vertical axis is composite endpoint of death or heart failure stay, and cardiac death in middle or heart failure hospitalizations. In no circumstance did salt restriction help these people. Now that's totally intuitive, right? It's counterintuitive to think that if somebody is holding on to extra salt and water, that reducing salt intake will not make them better. But here are the evidence. It doesn't work, okay? We're not sure why it doesn't work. You can read that study, every single group, it didn't make any difference whether you were on different drugs or not drugs or what your etiology was, it didn't work. So unfortunately, salt and water restriction doesn't work. Okay? So I wish I could tell you it did. I've had one person where water restriction did work. It was a guy whose serum sodium was 108, and turned out, we admitted him to the hospital, and his roommate said, hey, he's been drinking out of the toilet. Guy had polydipsia. He had a psychiatric problem. So, occasionally it'll work. But do not, salt and water restriction do not help. Okay. More importantly is what I would call disease-modifying therapies. So diuretics are for symptom relief. Now let's talk about how do we make the heart better. And you already heard from Chris that the renin-angiotensin system gets turned on, and that's a bad thing. And in heart failure, this gets turned on in spades. And really, it's a bad thing. Right? So initially, the first drugs that helped in this were the so-called angiotensin-converting enzyme inhibitors, right? Discovered because a snake bit people in Brazil, and the blood pressure went down. It turned out they had an ACE inhibitor in the venom. And so they said, maybe this will work for hypertension. So the ACE inhibitors were first tried in hypertension. And then some smart people said, gee, maybe this will work for heart failure. Now, remember that these drugs are not used for blood pressure restriction or reduction in heart failure patients. The reason we use them is not to lower blood pressure. It's to alter the adverse milieu that occurs in patients with systolic heart failure. These are all systolics we're talking about because we have no diastolic data that these drugs help these patients. Many drugs are available. Most have been tried in heart failure. Most probably work. Okay, so whatever your favorite ACE inhibitor is. In the U.S., that tends to be lisinopril is the number 1, but that isn't because it's any better necessarily. So they're proven to work, the ACE inhibitors. And ARBs, which of course came out later and are manufactured, there is no natural ARB in the world, angiotensin receptor blockers also work. And they are probably very similar in terms of their end result for heart failure. So ACE inhibitors, great, ARBs, great, your choice, doesn't matter. You heard about spironolactone, I'll show you data in a minute. That's attacking a different angle of the renin-angiotensin aldosterone system. It blocks the mineralocorticoid receptor, terrific addition. And then most recently, in the last 2 years, we have a different way to attack this, which combines an ARB with an enzyme inhibitor. The enzyme that is being inhibited degrades many peptides in the body, including vasodilator peptides, and that is called, the literature calls it ARNI, angiotensin receptor neprilysin inhibitor. There is only one ARNI, the trade name is Entresto. It's the combination of sacubitril and valsartan, and as I'll show you, that works better actually than an ACE or an ARB, we think. Hasn't been pitted against an ARB yet, but it has against an ACE. So how much do ACE inhibitors help? Here are the original 6 trials, the only 6 trials, ACE inhibitors versus placebo, and the average reduction in death, and these go back when we had no other therapies. So this is nothing versus an ACE inhibitor, essentially. And the ACE inhibitors reduce death by 20%. Okay, so that's pretty darn good. 20% death reduction is quite good. What dose should we use? We do not know. I wish I could tell you what the best dose of lisinopril, benazepril, accupril, anything else. Truth is, we do not know. And the reason we don't know is there's only been one trial in the history of man which pitted 2 different doses of an ACE inhibitor that was lisinopril, but they chose basically 2.5 milligrams versus 32.5 milligrams. And, you know, I'm not sure that was the most edifying trial. But if you look at big databases, right, this is the metadata, let's look at the last 100,000 people, it looks like higher doses are better. That if you look at death or heart failure stay, where the final, you know, is 20 milligrams of lisinopril better than 10? Probably. Is 40 better than 20? I don't know, maybe. Is 80 better? I don't think so, but we don't know, right? So I would just say to go to what we call target doses. Target doses means the doses that have been used in the trials, but I will tell you we do not know whether those doses are the optimal doses. This is the combination that I mentioned a minute ago, sacubitril, valsartan. It uses our old friend valsartan and combines it with this new drug that's only available in this particular complex. And this was pitted against the ACE inhibitor enalapril, which was the standard used in years past. And what this trial showed was that in the largest heart failure trial ever done, 8,442 patients, if you chose to put somebody on enalapril, blinded fashion, or the sacubitril with valsartan, blinded fashion, the new drug did better. And I want to point out one thing. You saw statin trials earlier today that Ezra showed. The statin trials took between 6 and 18 months for the curves to diverge in favor of statin over placebo. This curve, hard to tell on this slide, but I'll tell you that by 30 days, the curves had statistically and clinically differed in favor of the new drug. And the difference was 20% extra benefit beyond an ACE inhibitor. So look at this as kind of a super ACE inhibitor. It's instead of an ACE inhibitor, it's better. And it was better throughout the 2.5 years. The trial was stopped early because of its betterness, right? The DMC, the Data Safety and Monitoring Board said we can't ethically continue this. 16% fewer deaths, number needed to treat between 20 and 30 patients to prevent an event in the next 27 months. So we now have something better than an ACE inhibitor. In our heart failure program, 100% of our patients have been switched from their ACE or their ARB to this particular drug. Spironolactone. Absolutely would like to second what Dr. Mendy said earlier. If you have a refractory or difficult hypertensive case, this is the drug you should go for, spironolactone. It's also terrific for heart failure. Here is a trial of systolic heart failure. Remember I said the ACE inhibitor reduced mortality 20%? This one reduced mortality 30%, spironolactone. And yet in the United States today, fewer than a third of people are on spironolactone with reduced ejection fraction heart failure. So this is a missed opportunity for us. So use more spironolactone. It prevents fibrosis and disease progression. It does have a bonus effect as a diuretic, but that's not why we're using it here. This blocks the mineralocorticoid receptor, which most people think is stimulated by aldosterone. True, but in heart failure, most of the stimulation is other steroids like cortisol. So that's where the benefit comes in heart failure. Watch the potassium level because obviously 5% or so of these people will have hyperkalemia. If you combine spironolactone with either ACE inhibitor ARB or Entresto. And if that's a problem, there are potassium binding agents you can use now to bring the potassium back down. Okay? And lastly, as I said, the guideline preference is to use the newer sacubitril-valsartan combination instead of an ACE inhibitor or an ARB. Now, what about the effect of heart rate? Chris mentioned heart rate a moment ago in the context of hypertension. Well, there's an interesting dichotomy here. So what most people didn't understand is that when the heart starts to struggle, the heart is genetically reprogrammed. And the heart goes to fetal genotype and phenotype rather than adult phenotype. And as such, the heart begins to, in a sense, turn itself off and hibernate. That's what happens in systolic heart failure patients. And here's graphic demonstration of this. These are human hearts. And green is a human heart that's just been taken out of a patient and thrown into the trash bin for a heart transplant, basically. In red is what a normal heart does. And what your heart, assuming your heart is normal, does is that the faster the heart beats, the stronger it beats, up to about 160 or so. And then it starts to weaken, which is why you get tachycardia-induced problems. But at 110, it's better than at 100. And 130, it's better than at 110. That is not true of the heart failure patient. If a person's EF is 30, the faster their heart goes, the worse it gets. And in fact, these hearts, at a heart rate of 30, if you take the heart out, these are papillary muscles, you put it into a petri dish and you measure how strong the contraction is, and these are people with EFs of 20, turns out at a beat of 30 beats per minute, their heart's just as strong as a normal heart. So unlike normal people, when you slow down the heart of a person with heart failure, their heart gets stronger, doesn't get weaker. And that's what misled us for the first 20 years that we had beta blockers, right? Because we thought that a failing heart would act like a real heart that wasn't failing. In fact, if you look at the first trials, so we're going back now 20 years with metoprolol succinate, on the right-hand side is what happens to the ejection fraction on metoprolol. There are two ways to increase the ejection fraction more than 3 points in a heart failure patient. Okay? One is to resynchronize them with, if they have a left bundle branch block, with a biventricular pacer. That's about a $50,000 device. Or you can give them a beta blocker. Right? Both will increase the ejection fraction 9 percentage points. There is no other therapy you can do to increase the ejection fraction 9 percentage points, let me tell you. When that was put into the clinical arena, 3 drugs emerged as being not only useful for slowing the heart, making the EF go up, but also improving outcomes. The mortality benefit was 35%. That's the biggest mortality benefit of any intervention we've ever had in heart failure. And that's why beta blockers are still the most important cornerstones of therapy. There are 3 that are proven. They're listed here. Bisoprolol, not used very frequently, but available once a day. Metoprolol succinate, which is the old Toprol XL, and carvedilol. Those 3 all have similar mortality benefits of 35%. But the hooker is you need to use the drugs to get the heart rate down. Otherwise, they're not going to work. It works in everybody. These are the different subgroups in the 4,444 patient MERIT trial. And the line of unity there in white, everything is falling in favor of metoprolol. So anybody with low EF, assuming they can tolerate a beta blocker, should be on a beta blocker. Now that said, here are some US data of 2,300 patients. How many were on target doses of beta blocker? What's the target dose? For metoprolol, it's 200 milligrams a day. For carvedilol, it's 25 twice a day, unless you're a fat person, and then it's 37.5 twice a day. And for bisoprolol, it's 10 milligrams once a day. How many people are on that dose? 20%. Another missed opportunity. Right? Just to increase the beta blocker. Right? It's not that hard. To reduce the heart rate, you can do that with metoprolol. You can do it with carvedilol, bisoprolol. There's a new guy in the block. For people in sinus rhythm, you want to slow the heart. If it's not slowed with a beta blocker, you can use the new one, is radipine. Let me just show you what happens when you do that. You lower the heart rate. The vertical axis is the heart rate reduction across different groups by an average of 10 beats. So let's take people whose heart rate's too fast. You lower it 10 beats. Here's what happens. Placebo versus, this is at Aberdeen, 6,500 patients. Total death was not statistically reduced. Death from heart failure was. This is heart failure hospital stay. That was reduced. Just reducing the heart rate by 8 more beats derived terrific benefit. Okay? And in fact, look at the heart rates here that we're talking about. I'm not talking about somebody who comes into your office with a heart rate of 90. The worst line in green was people's heart rates were 75 to 80. In pink, it's 70 to 75. The lowest one is 60. And the difference in events was reduced by half. If you bring somebody from a heart rate of 75 to a heart rate of 60, you've just lowered their event rate by half. There is no other intervention you can do to lower their event rate by half. So the biggest change that you can do in a systolic heart failure patient is to push real hard to get their heart rate down. We do that with increasing beta blocker doses or switching to a different beta blocker in some people because of polymorphisms. Not everybody responds comparably to beta blockers. There are people who respond better to one beta blocker than another. So please get the heart rate down to 60 in everybody. Now this doesn't apply to atrial fibrillation patients, okay? This is only sinus rhythm. Lastly, are there other things that might be considered? Yes, but I would put these down into niche things, right? So yes, there's some who are on digoxin and hydralazine, and a couple that would bear scrutiny. For example, fish oil. Turns out fish oil is useful, not to make your kids smarter, but to reduce events in coronary patients and in heart failure patients. Here's a heart failure trial that shows that fish oil actually helps. This is a very large trial. Other therapies, yeah, believe me, we have more, our group has more electrophysiologists than interventionalists. It tells you we're in Santa Monica, we don't have a lot of heart attacks, right? We have a lot of heart failure and atrial fibrillation. There are 3 times more EP people than there are interventionalists at our facility. But there's one other thing that made the guidelines last week, and that's giving intravenous iron. Why is that? This is not for anemia. This is because heart failure patients do not absorb iron. Iron, it turns out, is needed for the heart to beat, because not just red blood cells need iron, but so does myocardium and every muscle in the body, actually. So it turns out when somebody is low in iron, and it's everybody who comes to our clinic gets their iron measured. If they're low, they get iron, usually intravenous, because they don't absorb the oral. If you do that, what happens? Their ejection fraction goes up, their oxygen consumption goes up, they just get better. Right, so that's another one. Just made it into the guidelines with the revision last week. So give fish oil and replace iron if they're low. So here is the 2017 paradigm for medical management, okay? First, use diuretics to make them euvolemic. Use the neck veins to help you decide that. Then they need to be put on a renin-angiotensin drug, preferably the sacubitril/valsartan combination rather than an ACE inhibitor or an ARB. They need to be on a beta blocker. 5% of the people will need isradipine. The other 95% can get a heart rate in the low 60s on a beta blocker. And they need to be on spironolactone, or if they have gynecomastia, a Plerinone. And then we give iron and fish oil if needed. Now, and some, yes, will get defibrillators and biventricular pacers, etc. Those are a smaller number of people. If you do that, how many do you need to treat to have an event reduction? Left to right are a bunch of different trials saying number needed to treat, right? Carvedilol, treat 22 patients, you save 1 life. Enalapril is the next one. The next one is African Americans on hydralazine. The next one is a defibrillator. Notice that for a defibrillator, the number needed to treat is vastly greater than the drugs we're talking about, and the drugs are a heck of a lot cheaper than a device. Isradipine is the next one. The last 2 are a Plerinone, and then finally Entresto, the sacubitril/valsartan. You can make a big difference. In our clinic, the mortality rate, which used to be 10 to 11% per year, is now 3% per year. And that's a huge benefit both to the patients and to society. Thank you very much for your attention.
Thank you, Rich, for a great presentation and a great summary. Dr. Mendy. So if you guys look at the calendar that I gave you, I have 2 algorithms, one on hypertension and one on congestive heart failure. And they're virtually identical.